All right, so we'll go ahead and get started today with the AMSSM ultrasound case series presentation. So once again, a plug for the AMSSM Library of Sports Ultrasound Pathology. So this is a very great opportunity to take pathology that you see in clinic, training room, or the sidelines and turn this into a publication. So the AMSSM Sports Ultrasound Committee is still looking for both common as well as unusual pathology related to sports ultrasound. This is a really great way for residents, fellows, and even staff to add to the growing case series, the Library of Sports Ultrasound Pathology, as well as also get a peer-reviewed reference for your CV. And so more information for this can be found on the AMSSM webpage under the Sports Ultrasound tab. Also, you can always contact Josh Romero as well, too. So introduction for our speaker today is going to be Dr. James Gardner. He's currently a sports medicine fellow at Emory University. He went to medical school at the University of Utah and then finished his residency training in PM&R at the Vanderbilt University Medical Center. His main clinical interests include a full spectrum of medical care of athletes, overuse injuries, tendon pathology, as well as diagnostic ultrasound. And he will be joining the faculty at the Medical University of South Carolina as a sports medicine physician within the Department of Orthopedics and PM&R after this summer. And today he's going to be giving us a talk on an oblique strain. And just because of a schedule conflict, this had to be recorded today. So we'll start playing that now.
Good morning, everyone. My name is James Gardner, and I'll be presenting the AMSSM sports ultrasound case for today. I'm a sports medicine fellow at Emory University, and I just want to say thanks to everyone for the opportunity to present. Today, the case I'll be presenting is a case of a baseball player with an acute abdominal muscle injury. So we're just going to dive right in. I have no disclosures, just get it out of the way. And jumping right into our case, the patient we'll be talking about today and talking about ultrasound exam for is a 26-year-old male. He's a right-hand dominant baseball pitcher who suffered an acute sharp pain over the glove side, or the left side in this case, anterolateral abdomen immediately after pitching a fastball. So his exam was pretty basic and just showed tenderness over the left anterolateral abdomen at the costal margin. He had reduced rotational motion and strength because of the pain. Of course, there was high concern for an abdominal muscle strain based on the injury mechanism and the exam. This is a pretty commonly encountered injury in athletes that have explosive rotational forces like baseball pitchers, javelin throwers, swimmers, golfers, rowers, anything that's really high power through the trunk flexors and rotators. In patients with abdominal strains, they often can present with sudden pain and point tenderness at the region of the lower costal margin. And ultrasound can be super helpful in helping to establish the right diagnosis. And it's important to also use it to differentiate other injuries that could be present, even things like a rib fracture, injury to the costal cartilage, or even something like a Spigelian hernia or an epigastric hernia or something else that's a little bit more insidious. So moving right along, we're going to do a little bit of a anatomy review just briefly. I just want to remind everyone that of the kind of musculature in the anatomy. So the rectus abdominis is the paired muscle that runs over the anterior portion of the abdomen, separated by the linea alba. The rectus sheath is the connective tissue that encloses this muscle, both superficially and deep to the belly. And those tissues are formed from the aponeuroses of the more lateral muscles of the anterior abdomen. These are the external oblique, internal oblique, and the transversus abdominis. And of these, the most commonly injured is the internal oblique in this mechanism for throwers. This muscle originates from the inguinal ligaments inferolaterally, and it joins the transversus abdominis muscle to form the conjoint tendon that inserts at the pubic crest. These internal oblique muscle fibers are going to pass superomedially to insert at the inferior margin of the 9th, 10th, 11th, and 12th ribs, where they're going to intermingle with the internal intercostal muscle fibers in a position superficial to the intercostal neurovascular bundles. Another way to visualize this anatomy is, of course, in the transverse view from the superficial to deep, with an emphasis on the layers of the rectus sheath and their components. So this transverse schematic of the rectus sheath shows the relationship between the more medial rectus abdominis muscle bellies that are straddling the linea alba on either side. And then you can see the layers of the rectus sheath are actually formed by these aponeuroses, like we talked about, from the lateral, external, the more lateral muscles, the external and internal obliques, and the transversus abdominis muscles. And you can see that just deep to these is the parietal peritoneum. So importantly, today's scan is going to focus on the musculature above the arcuate line. So we are not going to be, that's where these injuries overwhelmingly occur. I just want to remind everyone that I will not be reviewing the structures below the arcuate line. And so this is not going to be an in-depth examination of the inguinal canal with its two rings or the neurovasculature there. We will not be going over the rectus, the distal rectus tendons, the pyramidalis muscle. Won't be talking about the pubic symphysis, adductor tendons. I would direct our viewers to other excellent videos on athletic pubalgia that have previously been published by other folks much smarter than myself for those topics specifically. Anyway, getting right into the protocol for this scan, we're going to begin with what I think is the simplest part of the scan to establish a home base at the superior muscle belly of the rectus abdominis in both the sagittal and transverse views with evaluation of the linea alba and the linea semilunaris. And then, as discussed before, we're going to go lateral to this structure and look at the rectus sheath as it becomes that triple layer muscle of the external oblique, internal oblique, and the transversus abdominis. And the key to this scan is, of course, identifying these distinct layers with their distinct orientations, with an emphasis on abnormalities in the muscle ecotexture and other soft tissues or bony abnormalities. So jumping right into the scan, I just want to orient everyone to what we're looking at. So the top right of the screen shows an abdomen with a blue line representing a linear probe and the way it's placed to obtain these images. And I'll be using a similar schematic for my other slides in the future. But you can see that we're looking at the natural home base for this exam is the midline of the abdominal musculature. This is a view in the transverse plane in the relatively hyperechoic linea alba in the middle of the screen on each of these pictures. And it's flanked on either side by the muscle belly of the paired upper belly of the rectus abdominis. The photo on the left is immediately subxiphoid, with the right photo at the linea alba at the widest portion of the upper belly of the rectus abdominis, so just a few centimeters inferior. As you can see, the linea alba becomes much clearer in this area and it's relatively hyperechoic. In some patients, you could see widening or disruption of the linea alba that could suggest pathology such as diastasis recti, which of course we don't see in this patient right now. We just see healthy continuous linea alba flanked by healthy normal looking rectus abdominis muscle belly, which we're going to take a closer look at. And just as a reminder, the preperitoneal fat is just below the linea alba, which is superficial to the parietal peritoneum. So you can see how close that rectus abdominis muscle belly actually comes to the parietal peritoneum itself. Next, we see the superior belly of the rectus abdominis muscle in a transverse view on the left and a longitudinal view on the right. You'll first notice that the relatively dark but uniform muscular ecotexture of the rectus abdominis, and you can see you'll notice the costal cartilage on the right of the second image, which is denoting the superior portion of the muscle belly. The fibers for some of the rectus abdominis will actually attach to the costal cartilage, whereas other fibers, you can see the more superficial part of that rectus abdominis, those muscle fibers are going to actually go all the way to the xiphoid process where they originate. In the more medial portion of the rectus abdominis, you may see the inferior epigastric artery running from the deeper posterior rectus sheath more superficially into the muscle belly in the rectus abdominis, which could be located with color Doppler. Here we're evaluating for homogeneity of the muscle ecotexture and of course sonopalpating as we go to correlate what we're seeing with symptomatic areas, as injuries of the abdominal wall tend to be fairly focal. Moving on, we go slightly laterally again. I'll just point the viewers to the top right of the screen to look at the abdominal model with the blue line representing where the linear probe is placed to obtain this image. We're slightly lateral to our previous image, and you can see the linea semilunaris coming into view in the middle of the screen with the muscle belly, the rectus abdominis to the left on the same depth. And you can see the layers of different muscles starting to come into view. The transverse view of the linea semilunaris isn't quite as well defined as the linea alba, but it's still fairly remarkable as the boundary between the large rectus and the smaller, thinner, more lateral external oblique, internal oblique, and the transversus abdominis. In this area, this is the site where you would see interruption of the linea semilunaris in a Spigelian hernia. So these are rarer types of hernias that can be caused by insufficiency through the transversus abdominis fascia with a protrusion in through the linea semilunaris of either preperitoneal fat or viscera, and can be a source of pain. Thankfully, that is not seen here. These are relatively normal looking muscles. So we're going to move on. Even more laterally, we visualize the three layers of the lateral abdominal musculature. The external oblique lies superficially, with the internal oblique followed by the transversus abdominis most deep. You can see that the fiber orientation is distinct for each of these. Remember that the external oblique runs medially, while the internal oblique runs superomedially. And these should each be inspected over their entire course, especially where there's concern for pain with sonopalpation. And while it can be challenging, I think it's helpful to visualize the longitudinal and transverse views of each of these muscles in their distinct orientations to get a sense for the anatomy, especially if the complaint is somewhat vague or maybe subacute. And if you're looking for a mass in this scan, we're looking for, not just pain with sonopalpation, but mass effect from an occult hernia, interruption of regular muscle fibers. There could be gapping or tearing or changes in echotexture. There could be intramuscular hematoma or a disruption of the fascia adjacent to the muscles. So a lot of different things that we're looking for. In this image, we don't see any of those abnormalities. We just see healthy, continuous looking muscles. And again, the parietal peritoneum is just deep to that transversus abdominis in this view. Next, we're going to keep moving laterally, and as we approach the inferior costal margin, you'll see that we reach the costal cartilage before we eventually reach the ribs, and this is just based on the orientation that I chose for this because it made sense logically to me. But I think that the orientation can throw some folks off. But again, looking at the blue bar to kind of see where we're scanning here on the abdominal model, you can see the cartilage allows for visualization of the transversus abdominis that's and the parietal peritoneum deep to it with ultrasound, whereas the true bony rib on the right shows the bone shadow. So you can see there's nothing really visualized below the rib on the right of this view. And remember that the internal oblique muscle fibers insert at the they insert at the inferior margin of the 9th, 10th, 11th, and 12th ribs, and they're going to intermingle with the internal intercostal muscle fibers. So they're essentially a continuation of the internal intercostals moving inferiorly. And so the insertion of these muscles onto the inferior costal margin is the highest rate area for abdominal strain. So that's where we're gonna pay particular attention to sonopalpation for pain, as well as any discontinuity in this region. So we're looking for muscle fiber changes, hematoma, etc. This is a more superior view of the inferior intercostal spaces. And again, I would orient you to the blue bar to see that we've actually turned the probe 90 degrees and have moved superiorly a little bit. These are possible sites of muscle injury in a similar mechanism to this case. Here we see external oblique muscle overlying the intercostal space. And again, remember that the external oblique originates as high as the anterior 4th and 5th ribs running inframedially. So it will overlie these more inferior intercostal spaces and the costal margin. As you can see on this image, the external oblique has normal echotexture. Of course, we are inferior to the lung field, so we don't see any airspace, but instead we see the peritoneum deep to these structures. And remember that the internal oblique is not visualized in this view, since it inserts onto the inferior border of the most inferior ribs and the costal cartilage. So we're not going to see it here, but it does run in the same plane as the intercostal muscles, which we do see deep to the external oblique between the inferior ribs here. So you can see these intercostal muscles between the ribs, and these all look healthy and normal. Here we have a video of a resting linear probe over the inferior intercostal space. You can see that the muscles have no disruptions in their echotexture. The peritoneum glides smoothly with changes. Let's see if this will load. Great. So you can see the changes in intra-abdominal pressure with each breath the patient takes, and things are sliding smoothly, but you can see that they move in different ways depending on which plane it is that we're looking at. This, of course, highlights the benefits of dynamic exam on ultrasound that you just can't get really from an MRI. But these all look continuous, healthy, and normal. Okay, in returning to our case, we're now visualizing the three muscles of the anterolateral abdominal wall as they approximate the inferior costal margin, which is going to be on the right of this picture. You can see the bright rib on the right side of the screen. In contrast to our previous images that were healthy and normal, there's a clear difference in the muscle ecotexture of the internal oblique, labeled IO, at its insertion on the rib, with disruption of the fibrillar structure of the muscle with hypoechoic changes. There was also reproduction of pain with sonopalpation to this area, which confirms the presence of an internal oblique muscle strain or muscle injury. This is the most typical muscle affected and the area for this injury to occur. You could measure the length of this defect for the report. We did not in this case, but for the full evaluation and documentation, I think that's a reasonable step to delineate the size of any muscle injury in at least 2 dimensions. And again, you can see that this is a somewhat more oblique view from what the ones we've been looking at previously were. Here we have a video of this same patient with an out-of-plane approach with a needle to inject the area with anti-inflammatory medication, as this was an in-season athlete with an acute injury trying to return to play. Unfortunately, there was air in the syringe, so that kind of mars the quality of the video. But I still think it's a useful educational piece on one approach for this procedure. You can kind of see the needle coming in out of plane here, approaching that defect. But as you can see, unfortunately, there is air in the syringe. Of course, confidence with ultrasound-guided injections is really important for this area. It would be really dangerous to attempt this injection without image guidance, given that the peritoneum is just a short distance deeper than the structure of interest. So for a report for this patient, this is what I would call a limited scan of the anterolateral abdominal musculature. The indication is acute left abdominal muscle injury. And again, our findings are there's normal ecotexture of the rectus. There's no widening or other heterogeneity or herniation seen at the linea alba or the linea semilunaris, and broad portions of the external oblique, internal oblique, and transversus abdominis are normal in ecotexture. But there were abnormalities in the internal oblique muscle at the inferior margin of the 12th rib, which showed, loss of that fibrillar ecotexture. There was a hypoechoic change with reproduction of pain on sonopalpation, which supported the diagnosis of a muscle injury of the internal oblique. So in summary, this is a less commonly done scan, but these are very common injuries in specific athlete populations. Sonopalpation can guide this scan, but I do think it's good to be protocol-based just to make sure that we're not missing secondary findings or other things that we would just want to make sure to take note of that could be causing a patient's injuries. And then again, the most common area for these injuries to take place is at the costal margin, and it's most often the internal oblique muscle. So both things to keep in mind when you're evaluating these athletes using ultrasound. These are my references, and thank you very much. Feel free to contact me with any questions, and I hope that this leads to a healthy discussion about the utility of ultrasound in this area.
All right. Well, that ends for the video. So now I'll kind of just start out with some comments here about this. I found this a very helpful presentation and lecture, just because there's really not that much literature on the topic really of abdominal or oblique strains, especially evaluating these injuries with ultrasound. So I think, as we had really focused on with this ultrasound series, is just really coming out with a protocol driven scan, just to make sure that you're not missing other injuries. And as Dr. Gardner kind of demonstrated here, I think really the major differential for these injuries in this area are going to be really trying to figure out where the muscle strain is. He had specified that the most common are going to be the internal oblique, but atypically these can occur in the other musculature. such as the external oblique, as well as then the rectus abdominis. And then other things that they had mentioned too to consider in your protocols are going to be evaluating for the hernias in this area, as well as in any other rib injuries, which at times you may need to get some other additional imaging modality. But really want to kind of just focus and emphasize that I do think ultrasound is an ideal imaging modality for these injuries. For a variety of reasons. Number one, obviously with the ultrasound, they're getting, very high resolution and can provide very focal and localized examination of these injuries, since a lot of these are going to be sonopalpatory, as Dr. Gardner had mentioned. And in addition, other positives of using ultrasound versus other imaging modalities is going to be a quick, easy contralateral comparison. And then also, if you ever need to look at these dynamically, some ways that you can do for this is obviously going to be kind of deep inspiration, as well as potential twisting motions that may create the pain and reproduction of the patient's symptoms, or even elicit, further pathology at this area if it's hard to evaluate statically. So I think going into these scans, it's important to kind of know the pathology as well as the injury patterns. And as mentioned in this, is that the most frequent is going to be the internal oblique, and really looking for those injuries at the insertion site of the inferior costal margin of those inferior ribs 9 through 12. I think going into a scan, as long as you're kind of knowing that, that can be helpful to really identify pathology. But once again, even though these are atypical injuries, as we had discussed with some other of these, is I would continue to just treat these as other, muscle strains. And so for that, looking both at direct and secondary signs. And so those direct signs are obviously going to be discontinuity of the muscle fibers themselves, but also secondary signs, as Dr. Gardner had mentioned, that you can kind of get that periosteal stripping or avulsion at their insertion of the costal cartilage or the ribs. And those are always, secondary signs that can kind of demonstrate that there's been either acute or chronic injury at this area. As we had mentioned, there's really kind of not too much literature using ultrasound and evaluating these injuries. So it will be helpful, potentially in the future, looking at a specific classification system, maybe for these abdominal or oblique strains, as well as then looking at return to play and whether imaging can kind of help guide that as well too, just because a lot of these injuries can be very prolonged in the athletes. So those are just some of the comments I wanted to make for this, but I'm going to go ahead and stop sharing my screen here so I can see if anyone else has any other questions or comments.
James and Stephen, thanks for the comments. James is Brennan Betcher. The other thing I would say, that was a fantastic presentation, something we don't have a great protocol guideline for. And I think you outlined that well. I think one other thing I would maybe consider looking for, and I think we don't really fully understand, or at least I definitely don't fully understand it at this point, but is slipping rib. And I think that's something that you'll occasionally hear people talking about with some of these like core muscle injuries and in athletes with twisting sports, is that they get instability of those kind of lower rib cartilage, instability of the lower rib cartilage, and that can cause similar symptoms, I think, than muscle strains and pairs can. So that'd be the other thing. And there is some ultrasound literature looking at this. Clinically, people use this hook test on ultrasound. People call it a push test, where you look for rib instability. And so that would be one other, consideration. But otherwise, that was a great presentation.
Yeah, Brendan, I think that's a really good point. But once again, something that I would emphasize, like that's where it's really helpful. And I think really ultrasound should be kind of the gold standard at looking at these injuries, just because, as you had mentioned, in the differentials, something like slip and rib syndrome, I mean, that's going to be dynamic, once again. And so other static imaging modalities, it's going to be difficult to evaluate for that completely. And so once again, I think there's just such high utility for using ultrasound, with these injuries for sure. All right. Well, unless anyone has any other comments, we'll go ahead and complete today's presentation. Once again, thank you, James, for recording this great presentation, which was extremely helpful. We'll go ahead and have our last fellows presentation in 2 weeks. And that will be from Dr. Brendan Hassad from the New York Presbyterian Cornell program. And he's going to be discussing a case on neurogenic thoracic outlet syndrome. So we'll see everyone again in 2 weeks.